This video will cover the present recommendations for prevention of COVID-19. When we talk about prevention, the first thing everyone asks is, what about a vaccine? Time does not permit a full review of this topic. I am not an expert in vaccine development. The protein sequence of S protein knobs is known, and this would be an ideal target for the vaccine. There are a number of unknowns with regards to which segment of the protein to choose, and issues with regards to what adjuvant agent that enhances the immune response should be chosen. Then field testing will need to be performed to prove effectiveness. Experts estimate the minimal time frame is 18 months. Optimistic earlier time points are being suggested by hopeful politicians, but I recommend assuming this realistic time frame and promoting the adoption of tried and true infection control methods that have been shown to be effective for centuries. This book, entitled Dissinformation, was written in the city of Florence, Italy in 1350 during the Black Death pandemic. The author describes behavior very similar to what is happening today. Many chose to ignore the mandates to shelter in place, and those who went to bars and congregated with others died, while those who fled to the countryside and isolated themselves survived. When we ignore history, we are doomed to relive it, and that is exactly what is happening in many parts of the United States. I hope other countries will learn from our mistakes. Infection control has been termed non-pharmacologic intervention. As outlined in the Imperial College COVID-19 Response Team's report of March 16th, there are 5 tools designed to control the spread of infection. Individual isolation. All infected individuals avoid contact with others and wear masks. They maintain a distance of over 6 feet. 2. Voluntary quarantine. Individuals who have come in contact with the infected patient agree to avoid contact with others for 14 days. 3. Social distancing of those over age 70. 4. Social distancing of the entire population. And 5. Closing of schools, universities, and non-essential businesses. These tools can be used to implement one of 2 basic strategies. Suppression. All 5 tactics are applied to reduce person-to-person contact to the level that drops the R sub 0 to below 1, so the number of new cases progressively decreases and the epidemic is suppressed, but not eliminated. Mitigation applies tactics 1, 2, and 4. Isolation, quarantine, and social distancing of the entire population to reduce the R sub 0. But the value stays above 1. In this approach, the epidemic continues to grow, but at a slower rate. Simulation studies reveal if the mitigation strategy is used, the number of individuals infected will rapidly exceed the capacity of the health system. In this graph, the black line shows what happens if nothing is done. The peak exceeds the ICU bed capacity, red line, by over 30-fold, upper graph. And the number of people estimated to die in Great Britain would be 510,000, or in the United States, 2.2 million. If mitigation is applied, the orange line, the number of ICU beds required to manage patients would exceed capacity by 35%, best seen in the magnified lower panel. The Imperial College team recommends suppression, employing isolation of infected individuals, social distancing for everyone, and school and university closings. Implementing this approach, the number of infected patients will never exceed the bed capacity and will minimize the number of deaths. The duration of the suppression strategy recommended is 3 months, and then upon discontinuation, watching closely and triggering isolation in place if a specific number of ICU beds again fill with COVID-19 patients. Discontinuation is allowed when the ICU bed occupancy drops below 50. Over time, the area under the epidemic curve becomes smaller and smaller. Other approaches for monitoring are also possible. For example, an internet-connected electronic thermometer sends body temperatures to a smartphone through a company called Kinsa, and then to an internet site allowing real-time regional monitoring of fever. A publication in the Clinical Infectious Diseases in 2018 documented a very close correlation coefficient 0.95, between the number of doctor visits for influenza-like illness and the number of individuals with fever. This simple smartphone application would allow close monitoring of COVID-19. This system can also be used to quickly identify new cases as we open up our businesses and schools. A word about simulations. Think of them as weather forecasts. They are not always completely reliable because they are dependent on predicting human behavior, a well-known challenge. Just because they don't always exactly predict the future, should we ignore them? Most people now listen to weather reports and act accordingly. Shouldn't we do the same with these epidemic models? In my original video on prevention, I asked several questions. First, will our health system rise to the occasion? The answer originally looked like a yes. Cases did peak in the U.S. on April 3rd and then began to drop after most areas observed shelter in place. Unfortunately, less populated states in the U.S. chose to ignore modeling predictions and did not shelter in place, continuing on as though there was no epidemic. As a consequence, we have seen multiple local outbreaks in many of these states, particularly in meatpacking plants. To make matters worse, many of the states that did embrace the suppression strategy gave in to the economic pressures, entering suppression after only 1 month rather than 3 months. As a consequence, the U.S. has failed to bring the curve to near zero. Instead, we are experiencing a prolonged plateau, with some states again experiencing exponential growth of cases. With the exception of Brazil, whose president continues to deny the risk of the virus, the U.S. has over 3 times the cases and 3 times the number of deaths from COVID-19 of any other country in the world. The consequences have been particularly troublesome in the southern states of South Carolina, Alabama, Mississippi, and Florida. As discussed in the epidemiology video in Module 1, the Imperial College has predicted a surge in Florida that is likely to peak in early July, and that prediction is presently being fulfilled. On June 20th, Florida experienced over 4,000 cases on one day, up from an average of 500 a day in May. This surge is primarily the consequence of increased mobility, the opening of bars, and congregating in large crowds over Memorial Day. Recent massive protests and an in-person political rally promise to foster a continued steep rise in cases in the U.S., and that will again be taxing our health systems. In a democracy, how can we achieve China's success? Unfortunately, as shelter in place ended, there was no central coordination of efforts. Public health and government institutions failed to encourage and train people on the proper infection control. In fact, many people believe the epidemic is a hoax and claim experts are lying to them. This represents a classic example of disinformation. Please watch the video addressing the dangers of disinformation in Module 2. Because of these conditions, large numbers of cases make testing, contact tracing, and isolation strategy nearly impossible to implement. We can't simply sit there and shake our heads. We all need to be part of the solution by leading. Now that you understand the problem, as healthcare professionals and concerned citizens, you must lead the charge and apply organizing methods to encourage everyone to faithfully follow the tactics required to drop R sub 0 below 1. We need to encourage 5 activities. Wear face masks. Avoid closed public spaces. Maintain 6-foot physical distancing. Avoid crowds and practice good hand hygiene. First, we all need to wear face masks in any enclosed public spaces. The evidence for their effectiveness is overwhelming. But seeing is believing. The scientists in this letter from the New England Journal used laser light source to show how droplets spew from your mouth even when you are talking softly. You will note the dramatic change when the mask is worn.
Stay healthy.
Great.
Stay healthy.
Great. Less loud.
Stay healthy.
Good.
Stay healthy.
Louder.
Stay healthy.
Louder.
Stay healthy.
Nothing.
There are multiple ways to obtain masks. You can make your own cloth mask, and I used the CDC template and made this hand-sewn mask shown in the upper left. This mask and many other cloth masks have a pocket where you can insert several layers of paper dish towels, the arrow, or a coffee filter. I also purchased humorous cloth masks from South Korea, masks from China, and ordered several handmade masks through Amazon Marketplace, bottom left. Our grocery store is also selling disposable surgical masks, bottom right. Remember the saying, I wear a mask to protect you, and you wear a mask to protect me. Wearing a mask shows that you care about others in your community. You should heed the advice of Pope Francis during his first public meeting since the onset of the pandemic. He warned against reverting back to individualism once the crisis fades. We all need to worry about each other's welfare. If worn religiously in public, we can continue to work, go to some commercial venues, and still drop the R sub 0 to less than 1. Face shields can also achieve this purpose, and my wife Kathy and I are now wearing them as an alternative to face masks because the face shield protects your eyes in addition to your mouth and nose. They do not become saturated with saliva and can be cleaned daily and reused. And at a dividend, you can see our expressions. 2. Avoid small, closed, unventilated spaces. Larger closed spaces are better, and outdoors is the best. This graph shows the relationship between space and ventilation with regards to the risk of being exposed to droplets. Whenever possible, enjoy the outdoors, and if you go to a restaurant, sit at an outdoor table. Finally, the longer you remain in a high-risk environment, the more likely you are to become infected. In general, avoid close contact for more than 10 minutes. Minimize being in public places. We have this plaque in our home. As never before, there is no place like home. 3. Maintain a 6-foot distance from others whenever possible, because droplets drop to the ground by this distance. 2 arm lengths is a good guideline for maintaining this distance. And be prepared to put on your mask if someone breaks into your protective zone. 4. Avoid large crowds whenever possible, because the more people, the more likely there will be someone in that crowd who is an asymptomatic carrier or even a super spreader. Depending on the prevalence of cases in your area, maximum numbers in a gathering should be 50 or less. In most cases, try to keep the number to below 10. 5. Finally, practice good hygiene. Wash your hands with soap and water for 20 seconds. Sing happy birthday twice. Cleaning of commonly used surfaces with a disinfectant is also advisable. However, to date, spread from surfaces has not been common. Remember, this is a campaign, but also remember we can no longer gather physically, and we need to use virtual campaign approaches. First, share personal stories of patients who are suffering from COVID-19. Remember Dr. Cece and the respiratory therapist. We each can share personal cases from the US, Europe, and the rest of the world. Find other like-minded champions using one-on-one communication. Write editorials, speak to your friends, and talk to our leaders. Post on social media and share the YouTube links I have included in the campaign packet that is part of Module 2. Hold virtual events to recruit others. We are all in this together. As never before, the world is an interconnected community. Our individual behavior impacts many others. And finally, remember, armed with the knowledge and understanding from this course, you too can make a difference. Thank you.